Hi, this is Stacey, the Babymaker Roberts. I have put together more than a decade of my clinical experience into developing the first online mentoring program that deals with the ever-growing area of natural fertility. My Babymaker Network Mentoring Program is an online interactive program where you will learn how to address all aspects of fertility issues. If you are ready to be a part of an atmosphere that helps you build your practice while helping couples build their family, I look forward to getting to know you in the Babymaker Mentoring Program. Please go to bioceuticals.com.au and click on the Education tab for more information and to register.
This is FX Medicine, and I'm Andrew Whitfield Cook. Joining me on the line from Chicago in the USA is Stacey Roberts, the Babymaker, a former physiotherapist turned herbalist and naturopath. Stacey has been involved in healthcare since 1989 in both conventional and complementary medicine. She's an internationally recognised natural fertility expert, and she's assisted people in over 32 countries with improving their overall health and well-being by addressing, I love to say this, not just their physical, but also their physiological and psychological health with complementary products and services. And I do really admire the way that you treat people as a whole person visiting you, indeed as whole couples. So welcome back to FX Medicine, Stacey Roberts.
Thank you, Andrew. It's great to be back.
I don't know what the weather's like over there, but it's a little bit chillier. You're just coming into summer over there, aren't you?
Correct. It's summer in Chicago, so I've been having hot temperatures lately, which is nice.
Yeah, but you've still got wind.
A windy city.
Not you. Sorry, I just realised what I'd said.
I take my probiotics every day, so I'm good.
Stacey, today on FX Medicine, we're going to be discussing a real quandary, something that affects so many, many women, and it's a real healthcare burden, and that is endometriosis. I think we really need to go first, though. What is endometriosis?
Well, Andrew, it is, right now it's actually being looked at as a possible autoimmune issue that women experience. But from what we know from the past, it really is adhesions or the part of the endometrial lining somehow gets outside of the uterus and then attaches onto the different structures outside the uterus, whether it be just the peritoneal cavity or the uterus or the fallopian tubes, the bowel, bladder. Heck, they've even found it in the knee and the nose. It's been found in different parts of the body as well, but mostly, in structures in the peritoneal cavity.
Yeah. I erroneously, maybe not erroneously, but I call them tumours sometime, but it's not really that, is it? Mm-hmm. But they are growths.
Correct.
But if I fall into that habit during this, just forgive me. I don't mean cancerous tumours. I'm just referring to a growth.
Sure, no problem. Yeah, it's more like a cyst if you imagine it. Let's say the endometrial lining splashes on the ovary, and the body, in its ultimate wisdom, tries to contain that tissue that should not be there, so it forms a cyst around it. And then every time we have a woman has a period, that proliferates and then can burst and cause other adhesions and other endometrial cysts around in different areas, and can be quite painful, but not necessarily.
Yeah, we'll discuss that in another question because I think it's something that's being perpetuated. But who is more at risk of suffering from endometriosis?
Well, the prevalence is 10% of women potentially suffer from endometriosis, but because sometimes there's no pain with it, that number is probably very understated. And in my clinical experience, I have kind of a stereotypical female who I always am suspicious of having endometriosis. And there's actually two. One is someone who's had polycystic ovaries who has not had a period for a period of time and therefore not having progesterone opposing her estrogen. So her lining can still be thickening, and then could potentially break away and cause endometrial cysts and things. And the other woman is someone who is always on the go. Her immune system seems to be depressed. She just pushes through pain. She's had pain since she was a teenager, but just takes medication every month and, just pushes through it instead of resting and listening to her, her body and figuring out what's wrong. Because every time she goes to the doctor, they say, oh, that's, normal. Just take this medication, Nephrogesis or whatever it is to get rid of it. So it's kind of the woman who's on the go, go, go. Now, those are, again, very stereotypical, and that will kind of tip me off to looking at it. But, any woman can really present with endometriosis, especially if she is most times experiencing estrogen dominance is usually what coincides with the endometriosis.
Right. So I'm thinking here that a lot of women who may think they're suffering from PMS pain, dysmenorrhea, they may well be suffering from endometriosis. It's just that it's not diagnosed because they just treat the pain as pain.
Correct. And so many people experience pain with their period, dysmenorrhea, and again, doesn't necessarily have to be endometriosis, but could be. But because so many women experience that, everyone thinks it's normal. Women just think it's normal instead of just common. So getting the point across to women that, it is common, but that doesn't necessarily make it normal.
Obviously, it's inside, so it's going to have that issue with diagnosis. But why is it so poorly diagnosed? And I don't mean poorly as a blame thing, but why is it so hard to diagnose?
I think it's difficult to diagnose based on the type of equipment that they have that's not sensitive enough to be able to pick those adhesions up and the cysts up on different areas of in the peritoneal cavity, different organ structures and things. It's easiest to find on the ovaries because they can detect a hemorrhagic cyst on the ovary, which whenever that is present, especially if patients have had past pain and dysmenorrhea that has increased during their period and then suddenly goes away after potentially that cyst bursting, then you can assume that potentially that woman should get investigated for or should have investigations done for endometriosis. There are also some physicians who are very, very good in their palpation techniques where they can palpate certain areas during an internal exam and, can, very much pinpoint the woman who's experiencing endometriosis by the feeling of those adhesions and those lesions that when they do an internal. So some of it depends on the physician's ability to be able to discover it, and then the sensitivity of the equipment, such as more highly sensitive ultrasounds versus the standard ultrasound that's done.
Stacey, I need to ask a question which, as I said before, is sort of perpetuated and maybe taken out of context a little bit. Is there an inverse association with tumour size and pain, i.e. more pain is less adhesions, and less pain you can get quite profuse adhesions? Is that the case in all cases?
Definitely not in all cases. You can have no pain and have no endometriosis, but then you can have no pain and severe, moderate to minimal endometriosis, and you can have extreme pain and no endometriosis, and minimal to moderate pain and again no endometriosis. So it really is all across the board. That is definitely not standard, and that's what makes it so difficult to diagnose without a laparoscopy, which is the standard best way to say whether or not a woman has it. And just to drop in about another reason why it's difficult to assess is because from an ultrasound of the abdomen, if the position of where the endometriosis is on the back of the uterus or on certain parts of the bowel, it would be very difficult for an ultrasound to be able to pick that up.
And what about the size of adhesions under the influence of hormonal fluctuations during the period? Does that change dramatically? Definitely.
So it tends to be estrogen dependent. So the leading up to ovulation, when estrogen levels are rising, that will be a time where if they do have pain, the patients will have pain at that time. Sometimes at that time and prior to their periods, they will have, prior to and with their period, they will not only have pain, but they'll have changes in their bowel. So if they have changes in bowel function from mostly to diarrhea, oftentimes that's a sign that there may be endometriosis present on the bowel. Another sign would be pain with intercourse. Again, something that women won't necessarily talk about unless you ask them, because they may think that's normal, or they may not even think about, because they have pain in a certain position with intercourse, that is indicative of anything. So it could also be indicative of constipation if their bowel, if they're not eliminating on a regular basis too. So nothing's ever really cut and dry with endometriosis, but you can get certain signs and symptoms. If you do a good enough evaluation, you can kind of, have enough information to either refer them on or obviously treat them with herbs and supplements that we can talk about in a little bit.
Yeah. So are there any long-term ill effects from endometriosis other than just pain and a little bit, he says, major discomfort? Is it just a painful sort of condition, or can it lead to real problems later on?
It can lead to fertility issues and potentially damage of the tubes, scarring of the tubes, and making it very difficult for a woman to become pregnant naturally. Other things, it can perforate the bowel if it gets extremely bad, and then obviously that's a huge issue. And and again, pain, missing work, not being able to function, quality of life, all those things are also potential issues with long-term severe endometriosis.
And I'm even thinking things like, as you said, scarring of the bowel, strictures and chronic bowel issues, and then you've got a whole sequelae of altered bowel function, hemorrhoids, even prolapsed rectums, and that just goes everywhere.
Absolutely. The emotional aspect of it too. If from a fertility standpoint, obviously that creates a significant emotional issue for the couple, but also, if they're having pain with intercourse and they're not subsequently not having intercourse, that can create problems with the couple as well too. So there's a whole emotional aspect that goes along with the woman dealing with endometriosis that is often overlooked.
So when you talk about scarring of the tubes, are we talking about a risk of safety there, for instance, like ectopic pregnancy?
Potentially, sure. If there is scarring of the tubes, or the tubes are altered in their structure or function for whatever it means due to having endometriosis on them. Obviously, if you think of endometriosis is a very inflammatory condition, very angry condition, from the point of that lining being outside of where it should be. Absolutely, that could be contributing to, like I said, infertility or potentially ectopic pregnancy if the fertilized egg can't get through.
And what about the success of treatments? Like you spoke earlier about, the use of NSAIDs and, naproxenic and things like that. I should say naproxen sodium. But how efficacious are they when we're just decreasing pain and a little bit of inflammation with regards to cyclooxygenase, with regards to the broad inflammatory aspects of endometriosis?
Well, as we know, those drugs long-term can create more problems than they solve. However, because they're only once a month per se for women who just have pain with their period, or twice a month that they also have with ovulation, it's often kind of looked at as, it's not a big deal. However, it's not addressing, the underlying problem, and therefore, the endometriosis can go on and on and on. So the other medical treatment is putting them on the pill. Now, for some women, this seems to work well with endometriosis, probably binding, the estrogen receptor sites and therefore improving their pain and potentially improving their estrogen levels, and then not having a problem when they come off the pill. But for other women, it seems to exacerbate their condition, where they actually have significantly worse symptoms, either on the pill or coming off the pill. Now, my guess, based on what we know from genetics now in the human genome, is there are probably women who have certain gene variations, certain SNPs that are going to be more susceptible to developing the endometriosis on the pill, or as other women, it would be more beneficial. So I'm excited to see that type of research coming out down the road, so we can be able to identify women who absolutely should definitely not be on the pill if they as a treatment for endometriosis.
And what about natural treatments? How efficacious are they? What herbs or interventions indeed stand out? I'm thinking here about things like yoga or acupuncture. What things work?
Well, again, as always, when we have our talks, Andrew, it's always dependent on the person who's sitting in front of you to see what's going to work.
Absolutely.
So we've got to evaluate, okay, what's going on with this person? So let's say somebody comes in with severe endometriosis. Sometimes in the public system, they'll go in for a laparoscopy and,
to my absolute amazement, what they'll do is go in and say, "Oh, yep, you have endometriosis," and then close them up and send them away without actually doing anything about it and taking it out. Yes, I've had that happen. So I've always instruct women to talk to their physician if they are in the public system that going to have the surgery, to ask the physician, if it's there, are you going to take it out, and what's your experience in doing that, and so that they feel comfortable with that. But when that's happened with patients who have had severe endometriosis, it's very important that they know that it can be a long period of time before they actually get relief, and then potentially the endometriosis being addressed and improving their fertility. For example, I had a patient who came in and she was in every single symptom of endometriosis. This was before I knew about what they would do with the public system and surgeries for laparoscopies related to endometriosis. She came back and said, "Yep, the doctor said I have it and it's severe," but they didn't do anything about it. She did not want to have another laparoscopy because she was afraid of more adhesions and scarring, so she just wanted to treat it naturally. And I just said to her up front, I said, with the severe nature of what you have and what you're experiencing, this is not going to turn around in 3 months. And it took us about 14, 15 months for her to be symptom-free, I would say 90% symptom-free, and another 6 months for her to become pregnant. So most women aren't that patient in regards to dealing with the endometriosis. So many times there's a combination of what we do in the clinic naturally to try to work on that estrogen dominance and rebalance the estrogen progesterone levels in a variety of ways, which we'll talk about in a minute. And then also, suggest that they go to a very skilled surgeon and have as much of it removed as possible, so that we kind of clean the slate and then can boost up the immune system, because the immune system's you're the best defense against endometriosis. Because when these adhesions and these cysts, when this endometrial lining gets into the peritoneal cavity, the immune system should go in there and clean it up. But if the immune system's suppressed or unable to do that, it's kind of, in my opinion, again, I don't have any scientific research to say this, but it makes common sense that the body kind of triages that. Endometriosis at that point is not going to kill you. So if the immune system has to take care of other things, then the endometriosis is left to continue to be a problem.
Right.
So then that's where the adrenals come in. As I said, the person who's on the go, always pushing, and their cortisol levels are high, and then gradually decrease. Over time, their immune system becomes suppressed, and again, they're decreasing their defense against the endometriosis. So the combination of the two, for some women, works well for them to have it removed. And then from a natural standpoint, what we want to do is identify, okay, if they have the estrogen dominance, is estrogen normal or optimal? And then is it low progesterone? So we go from the standpoint of addressing that through things like Chase Street.
Yep.
That's oftentimes a great treatment for that. Sometimes we need to look at, when there's elevated estrogen, either estradiol or estrone, we look at things like Schisandra, which is a great herb for boosting the immune system. It's a great adaptogen, and it's also great for supporting liver function. So that's a great herb to look at for endometriosis. And of course, from a pain point of view, we can look at Jamaican dogwood, we can look at cramp bark. But one thing I've noticed clinically with cramp bark, Andrew, is if you utilize cramp bark and the pain goes away completely, it's within the first month or two of using it, it's less likely that it's endometriosis. Now that isn't
that's good.
The case isn't the case all the time, but it's definitely been correlated in a number of cases over the years. So if you give cramp bark, if the practitioner gives cramp bark and it barely does anything to the pain, or even moderately reduces it, but there's still a moderate amount of pain, then again, the practitioner should be thinking, okay, this could be endometriosis.
Right.
Now, from a nutrient point of view, to decrease some of the inflammation, we've got NAC, which I love NAC. We've talked about that previously.
Yep.
And using NAC 3 times a day at 600 milligrams has been shown in studies to help with endometrial lesions. So that's a great treatment as well.
600 milligrams course, 3 times a day? 600
milligrams 3 times a day.
Yep.
And that study, I believe, was either 12 or 14 weeks where they did that to address the endometrial lesions for women. And then the one that we've talked about the herb that we talked about already too is, turmeric or curcumin. I just love as an anti-inflammatory, and that's supportive of the immune system as well too. So a fantastic herb to utilize as well in your toolbox. What else? Fish oil from an anti-inflammatory point of view, and that's been shown to decrease post-operative inflammation and adhesions as well for women who are having endometriosis removed. And of course, probiotics is, again, a mainstay for me to boost the immune system. And because there's some research on probiotics being involved in estrogen metabolism, it doesn't surprise me that besides boosting the immune system, that probiotics can also help to support women who are dealing with endometriosis.
You mentioned fish oil, and there was an interesting paper I was looking at from 2012, Iranian Biomedical Journal, evaluation of the relationship between endometriosis and omega-3 and omega-6 polyunsaturated fatty acids. And basically what it's talking about is that the levels of fatty acids in the serum did not seem to be a marker for endometriosis, but it did seem to be related to the severity of the illness, which is interesting when you look at the potential pro-inflammatory aspects of omega-6 polyunsaturated fatty acids. So do you find that when you're getting these women on, a high polyunsaturated 6 fatty acid diet or a low omega-3, do you find that there's a real impact when you change that around and you add the fish oil in?
Yeah, so that wouldn't be something that I would be looking at for endometriosis because most diets are high in omega-6 anyway. So, and with endometriosis, typically red meats, dairy, sugar, those things seems to exacerbate the condition. And when I looked, I learned that in school, if your patient has endometriosis, or possibly, get rid of red meat and dairy. And there was never really good explanation other than, that's potentially inflammatory. But as I've looked at some studies on patients who are looking at dealing with cancer, what they found with red meat and dairy is there's a certain molecule, a glucose molecule, present still in those animals that is no longer present in humans. So when we ingest that food, we do have an inflammatory reaction against that and create antibodies against that molecule. And then that makes a lot more sense because, again, that inflammation, kind of like a food sensitivity anyway, creates a problem with the immune system, and those who would be susceptible could go on to developing the endometriosis. So removing those three things is extremely important for somebody dealing with endometriosis. It
actually ties in, forgive me, I've just re-looked at the abstract for that study, and it was talking about the serum ratio of EPA to arachidonic acid, which of course is involved in red meat consumption, was in reasonable correlation with the severity of endometriosis. So that's where that pro-inflammatory aspect of certain omega-6 comes in. But maybe there's a use for evening primrose here. It's basically sort of fallen out of favour. Do you find it works?
I don't see that it works on its own, except for, I would say, breast soreness. I do still see women doing really well with it, evening primrose oil on its own. But I like to use it in combination with the omega-3s, again, as balancing that.
There we go.
That omega-6, omega-3 ratio. And, we know our plant omega-3s are not necessarily as inflammatory as the meat-based omega-3s as well, too. So, from the standpoint, using evening primrose and fish oil together, I will use that in rheumatoid arthritis. That's a bit off the topic, but another autoimmune issue for rheumatoid arthritis, which, again, they're saying endometriosis maybe.
Yep.
To utilize those two together, there's some good research on that decreasing symptoms in rheumatoid arthritis. So it wouldn't surprise me, if there was a study supporting the use of both with endometriosis as well.
Yeah. Are there any natural therapies which you find are of no use or of little use?
I guess my brain always goes to what actually works. So acupuncture has worked for some women in regards to pain, and for some women it doesn't work. Massage, abdominal massage, visceral massage, which is a technique that physiotherapists often use to try to break up fascia, and adhesions in the fascia that's around the organs in their body and muscles. That has worked, again, in some women and has not worked in others. So I guess it depends on the severity, the involvement of the patient, and also, the practitioner that's performing the intervention as well too.
Yeah, both. There's two comments there that you made. When you said seek out an expert physician, and it's kind of like what do you call the worst doctor in the class? You still call them doctor. Okay. And likewise, I think this is a call to action for any natural health practitioner that really wants to become expert in this. You really should be doing the Babymaker program to learn about this sort of condition in depth, because this is seriously the tip of the iceberg we're going through here. You'll be covering this sort
very quickly. Absolutely.
Yeah. You'll be covering this in a lot more depth in the Babymaker program, right?
Absolutely. We'll go into case studies so that when you get a report back where they've had either moderate, severe, or minimal endometriosis, you'll know what to do. You'll know what to do if they suspect endometriosis, and how to treat that person that has the estrogen dominance. And estrogen dominance is just, there's not one herb for estrogen dominance. It's about, okay, how did they develop the estrogen dominance? What's the cause of that? And then figure out what the causes of that, to be able to address it. So we'll have multiple case studies going over it, and then going over endometriosis in great detail, as well as other issues with estrogen dominance.
Yeah. So can I just ask then, what should women, or indeed couples, do when seeking advice about having a child when endometriosis has been a factor in the woman's life? How do they go about seeking help that's going to get the best outcome for them?
Well, a couple things come to mind with that, Andrew. First is that just because she's been diagnosed with endometriosis doesn't mean that all the focus should only be on her. We've talked about this as well in other podcasts, that the male fertility is often completely overlooked, especially if there's a diagnosis for the female. So number one, it would be that both people, do what they need to do to optimize their situation. And I've written the book, The Fertility Bible, the 5-step fertility solution. So optimizing their eating plan, minimizing toxic exposure, which is a big one also for endometriosis, optimizing their supplementation program, exercise, and stress management. So that's across the board what both of the members of the couple should be doing. Then if a woman has had endometriosis in the past, there's a chance that there's scar tissue or adhesions there from previous removal of endometriosis, because that's most times when the only reason that she knew she had it is because she's had it removed. So that might be someone who would have a exploratory laparoscopy a lot sooner than someone else who has never had a diagnosis of endometriosis, to make sure that any adhesions or scarring has not been a problem. Or it's also familial, Andrew. So if a sister has had it or a mother has had it, that also may be another reason to have an exploratory laparoscopy sooner. Now, if the patient doesn't necessarily want to have that surgery, that's fine too. What I do is then explain to the patients, we get blood tests, we look at their estrogen progesterone levels. We can also look at an indicator called CA125, which you mentioned ovarian cancer earlier, is that can be an indicator for ovarian cancer, but in some cases, it can also give us some clue if it's elevated, if there may be endometriosis present.
Yeah.
So it's not 100% accurate for that diagnosis, but again, it's a piece of the puzzle that can say, maybe you should have this exploratory laparoscopy.
Yeah.
But we utilize all of our other tools in the toolbox of, suggesting blood tests. What is their thyroid doing? The thyroid influences estrogen metabolism, progesterone production. What's their adrenals doing? That's going to influence their immune system and progesterone and estrogen as well. So we have to assess all of those things as well too.
I think CA125 has sort of had a bad rap. It's sort of saying don't use it for a diagnosis of ovarian cancer. And so the sort of underlying, assumption there was don't use it. That's wrong, because even though it's not specific for ovarian cancer, it's telling you there's something going on. And so even if you measured it as I know it's not screening, but if there was reasonable cause to suspect there was something going on in the woman's abdomen, I would still use that anyway to say, if this is high, it's certainly a reason for further exploration, correct? Correct,
right. So sometimes things get pushed aside if there's if it's not 100% always directly related to what the physician or researcher is looking for. Well, to me, that seems a bit crazy. You're throwing the baby out with the bathwater. Like you said, there's something going on if this is elevated. So why not have more exploration as to what that might be? Yeah. And from our point of view, the naturopathic point of view, we always want to explain to the patient what their options are. And I'm not a big proponent of surgeries, but when I deal with the fertility population, their perception is they're on this time, issue where they lack time. So if I can help them combine conventional medicine with a very skilled, physician, surgeon, and natural treatment together, certainly they can have a better opportunity to become pregnant. I hate to say faster because that's such like a marketing term, but more quickly, by addressing some of the underlying issues straight away.
Yeah. I think the problem that I have with pigeonholing CA125 as being of no import is kind of like saying, well, hang on, if that's the case, why are we testing prostate-specific antigen? Because that's not specific. For sure. Which is a weird name for it. But anyway, I do want to just ask a question. There was a really interesting study that I was looking at, and it was talking about the combination of NAC, alpha-lipoic acid, and bromelain. Now, it was a mouse model, but it was in vivo and in vitro, as a model of endometriosis, showing some quite dramatic reductions in numbers, size of cysts, really quite incredible results. Do you ever use that combination, or do you just choose various things that work and see what works in that patient?
I've used that combination, not necessarily purposefully, actually kind of accidentally, whereas the alpha-lipoic acid will be in the multivitamin that I'm giving the patient, and I'll utilize bromelain as a great anti-inflammatory, and then utilize the NAC as well. So I guess I wasn't looking at those three in particular, but those would be a very common combination in the women that I'm seeing for endometriosis. So it doesn't surprise me based on what we know about those three nutrients that they have a great supportive effect, especially anti-inflammatory effect, and then decreasing. And if we can decrease inflammation, we decrease stress, right? So if we decrease stress in the system, that's going to improve hormonal balance, isn't it? So it's just kind of a knock-on effect.
Yeah. What about the use of, it's a bit of a favourite nutraceutical of mine, and that's diindolyl methane, or 3,3-diindolyl methane. Yeah. Do you use that often, sometimes, various patients? Tell me your experience with this compound.
I absolutely use it with patients, and if I've done requested blood tests, and the physicians have been kind enough to provide the blood test for the patients to do of estradiol and progesterone 7 days post-ovulation, and then estradiol on day 2, and they consistently are high in estradiol or have the estrogen-dominant symptoms such as sore breasts, pain leading up to ovulation, some spotting around ovulation, those types of estrogen-dominant symptoms, and I've confirmed that they're either the estradiol, E2, is high in blood, and or E2, E1 high in saliva. I have seen the best results with DIM. I love it. It is. I don't often use it with estrogen dominant symptoms if it's just progesterone deficiency.
Yep.
No, it's not indicated. Doesn't appear to be necessary. Right. It's not indicated, and it can be quite costly in some cases. Yep. So, but I found it to be extremely effective for women who just have the symptoms, estrogen dominance, and or endometriosis as well.
Yeah, I've used it in any sort of proliferative disorder, even hemangiomas, but which is sort of, I guess, but my issue, I'll just sort of put in a caveat here. Some people say, oh, well, I use indole 3-carbinol. I'm not such a fan because the proponents of I3C talk about the 2:16 ratio ad nauseum. They carefully admit the inverse actions on the 4-hydroxyestrogens, which are extremely proliferative, and that's where further research needs to be done. So I'd like to see wherever indole 3-carbinol is utilised, I'd like to see some measurement of the 4-series estrogens, and indeed, if practitioners have their own experiences in measuring this, let us know on FX Medicine. That'd be great.
Absolutely. And personally, I did go through a period of time where I wanted to try a couple other products, the indole 3-carbinol, and there was such a marked difference in the patients who utilize DIM and such a faster response to them utilizing DIM than I ever found with Endo-3-carbinol. So I have not used it. I don't see it in my practice being helpful. DIM is really where I'll go.
Yeah. So what about caveats? What about warnings or things that we've got to be really cautious of if we wanted to treat?
I would say what we talked about in the beginning is being very honest and upfront with the patient who has all the symptoms of endometriosis, or at least a majority of them, and letting them know if they don't want to have the laparoscopy, which is totally fine, that it can be a period of time before things are that they are seeing improvement. There is actually one herb before I go on to another caveat that's been used along with the pill in the study to look at women who've been on endometriosis or who had endometriosis and been on the pill, and then women who've been on pine bark extract, maritime pine bark extract.
Yeah.
And they were on the pill for, I would say, a year, 12 months, and then the same with the pine bark extract. And they came off of that, both of them, and the pine bark extract had the same impact while on it than those with endometriosis who were on the pill. And then also the symptoms came back more quickly in those who had taken the pill than they did in those who had been treated with the pine bark extract, maritime pine bark extract. So that's another herb I don't utilize as often because I've found it more difficult to find.
Yeah.
But the research definitely supports that. If as a practitioner you can get your hands on some maritime pine bark extract.
Wow, well done.
Another caveat, I guess, with patients is educating them, and if you have a bias against medical practitioners, which some natural practitioners do, I'd say put that aside for the person who's trying to deal with potential endometriosis and improve their fertility at the same time, and let the patient decide what route they want to take. But do your research as a therapist, as a practitioner, to find who to refer to.
Yeah.
There are certain people that I would not refer to, and there are certain people that if I had endometriosis that I would definitely go to. So that's word of mouth and talking to people and letting patients know if you don't know the doctor that they're going to see, giving them the questions to ask the doctor. How many times have you done this? Have you ever had any complications with this surgery? Is there ever a time where you don't take the endometriosis out? Those types of things will give them a hint to their skill level and their confidence level in dealing with endometriosis. So,
yeah. Very good tips, good practical tips for people to ask their medical practitioner, whatever their condition. I think it's really important for patients to be empowered. Doctors don't necessarily dislike this. It's all got to do with, being a practitioner, and indeed it's part of their job, part of their legal framework. So I just wanted to drop in a point that we were speaking about earlier regarding the cost of endometriosis. endometriosisaustralia.org/research. 1 in 10 suffer from endometriosis. 176 million women worldwide suffer from endo. But the average cost of endometriosis per woman per year, now this includes things like non-work related as well as work-related activities, is up to around about $12,000 per year when you're talking about time off work, problems with pain management, medications, what about shopping and study, childcaring, costs, all of that sort of thing. $12,000 per woman per year. That is a huge healthcare cost that needs addressing. That's massive.
Absolutely. And it needs to be addressed when they're in their teens and they have this pain and these problems, and instead of just putting them on the pill and prolonging the problem for many of the women, again, working with a complementary practitioner along with the physician to help them address the pain, but also preserve fertility for later, decrease these healthcare costs, more of a preventative type thing.
Yeah.
Than dealing with it when it becomes a real issue down the road.
That's a good point that you make just there. What age does it normally present from?
I've seen girls as young as 14, presenting with symptoms that could be endometriosis. Now, most physicians won't want to do laparoscopy unless there's significant quality of life issues at that point in time, and they'll wait till they're 16, 17, 18, sometimes, up to 21 before they'll look at it. So again, those are the girls that are then put on the pill to try to manage the symptoms instead of address the reason why they've experienced the endometriosis. And those are the girls that are taking the anti-inflammatories on a regular basis. And when I was a coach many years ago for basketball and volleyball in the U.S., there were girls literally taking these, naproxenics. I'm trying to think of the name of it, of one of them. But they were taking them like candy during their period. And their parents didn't know any better, and the physicians, and they'd have stomach issues and all these types of things. So
wow.
As young as 14, I know that I've seen patients with having the symptoms, but, 17, 18, 19 who've had confirmed cases of endometriosis and have had laparoscopies to address it. It can happen extremely young. Once they start menstruating, of course, they're going to be susceptible to it.
Yeah. Okay.
And then you're talking before about being off work. Well, these kids are off school. They miss school. They miss social activities. They end up in bed for a week at a time with their period. So it can be quite a emotional time for those kids as well too.
Stacey, again, I would implore all practitioners to do your course, the Babymaker program, which will go through endometriosis and, of course, all of the other issues with regards to fertility in far greater detail than what we've gone through today. But I really do thank you for taking us through some of the more important points that are affecting not just, diagnosis and some treatment issues, but how it affects couples. And that's one of the real key things that I think you address so perfectly, that you will always address these people as people, not just a diagnosis. So thank you once again for joining us on FX Medicine.
Well, thank you for having me, Andrew. I really enjoy my time with you guys, and I really encourage anybody who's interested in the Babymaker program to talk to their representative at Bioceuticals, because it's just 5 to 7 hours worth of endometriosis and estrogen dominance and those types of issues is what we'll go into versus the information we presented today, like Andrew said, is really just skimming the surface. And
I can tell you right now, the feedback that we're getting is rather awesome for that. Some people are just blown away by the depth that you go into. So well done.
Thank you. Appreciate that.
This is FX Medicine, and I'm Andrew Whitfield Cook. This podcast was proudly brought to you by the Babymaker program with Stacey Roberts. This is Andrew from FX Medicine. We thank you so much for your support over the last 2 years. We'd really love to remain clinically relevant to your practice. So if you know of an expert in some area, please let us know. You can contact us on fxmedicine.com.au, Facebook or Twitter.